A big thank you to RMA Westchester and CooperSurgical for having us all here tonight. We have a wonderful evening planned. We're going to have great conversation, great chat just about a lot of the topics that either we're going through, you know someone that's going through. My name is Jenna Wolfe. I will be your host this evening. I'm happy to be here for a number of reasons. One, tonight's conversation really hits home for me on so many levels, so many personal, important levels. And two, being here tonight means I'm not there tonight, and there is at home doing bedtime routine, which is a nightmare at my house. I love my kids. I love them so much, but come help me with math, but if it takes longer than 3 seconds, never mind. I can't use the same towel for my face and my body. Like, we get a dog. I'm like, why are we, every night, all the time. But I love my kids. I love them so much more than anything on earth, and because of the reason that I love them is why I'm here tonight. Harper and Quinn, ages 10 and 8, those are my girls, going on teenager. So I'm sure there are a lot of people here going through that as well. I'm excited tonight, though, to be driving what I hope and know will be a very riveting conversation. We're going to talk about the BRCA gene, which I now know a lot about fertility. We're going to talk about breast health and empowering choices, right? The choice to put your health and your priorities first in your life. And I'm going to be joined in a minute by 4 of the brightest minds in this field. They didn't say that, but I did. As well as a patient of one of these doctors who will talk about her BRCA journey, Caitlin. But we'll get to all of that. First, I would like to tell you a little bit about my BRCA journey. My mom, who is here in the audience with us, as well as my dad, because they're inseparable. My mom was diagnosed with triple-negative stage 3 breast and lymph node cancer during the pandemic, and it was not pretty at all, and that's putting it gently. She went through hell, and she did it with only my dad by her side because it was the pandemic, and no one was able to really go visit her. Yes, she was here in Westchester, where they live, but everything was on lockdown, and so they were basically stuck up here, and it was gut-wrenching to watch her go through that. And I'm going to share a quick story just to give you an idea, because everyone has that one story where they were like, oh, that's cancer. So for me, it was one Sunday afternoon, and my kids were 7 and 8, 6 and 7. They hadn't seen my mom in a while, and my mom hadn't seen the kids, just on FaceTime, and my dad decided to take her into the city. So he carried her into the car, and they drove from Croton into the city, and they pulled up on my block, and they called us, and we came to the window, and he walked her out of the car, and she just sort of stood there, and my girls ran to the window, and they were just waving at this like frail, old, almost unrecognizable woman that was my mom, and I hadn't seen her either, and I said, this is my moment. This is what cancer is. This is up close and personal. And I get it now, and I understand what she was going through, and it's amazing because she beat it, and she's so strong and wonderful, and so I have a new respect and understanding for the journey of what people go through with breast cancer. So anyway, my mom beat it. She is fine today, but she did test positive for BRCA. That's for you, Mom, all of that. Of course, my dad's not proud. He was there the whole time. She tested positive for BRCA. I tested positive for BRCA as well. So my surgeon sat me down, my doctor sat me down, gave me 2 options. 1, MRI every 6 months, or 2, surgery. And for me, it wasn't even a choice. It wasn't even an option. So a week later, I was in the hospital, having elected to undergo a full hysterectomy. 3 weeks after that, I had a bilateral mastectomy. And 3 months after that, I had a full reconstruction. All of this in the last 8 months. All of this with no regrets. It's exactly what I needed to do, and I listened to everyone, but I made my own choice. And today, 7 weeks removed from surgery because of my choice, right? Because I took matters into my hands about my health, despite how long it was going to take and how messy it was going to be, and it was really messy for me, and how my body was going to change because of my empowering choice. I am healthy, I am happy, I'm cancer-free, and hopefully I will be for a long time. Thank you. Well, this is part of thank you. The weight of knowing that your genes might or have already betrayed you, that's like a heavy burden to bear. And we were just talking inside about genes. I was like, why don't they just go in and take the bad gene out? And they laughed, and they're like, you'll never be a doctor. And you're right, I'll never be a doctor. But for me, I took all of the fear and the uncertainty out of the decision that was thrust upon me, and I turned it into this like tunnel vision focus on what I could do for myself, and in turn for my children, because that's going to be a big part of what we talk about tonight. Right? It's about you advocating for your health. It's a hysterectomy. It's not a hysterectomy you. That's what my kid kept saying the whole time. It's not a hysterectomy you, Mom. It's a hysterectomy. My little one said that a lot. But that's what keeps me up at night, my little ones. I worry about them. Like, am I going to give this to them? Are they going to have to go through what I went through? That's what keeps me up at night, worrying that these two beautiful souls that watched me, what I went through the last 8 months, are and might be faced with some of these same choices and decisions that I had to. So that's what we're going to talk about tonight. That was my story. I'm honored to have shared it with you. I'm honored to have, been able to feel comfortable to have my mom here with us tonight, to be able to sit and explain and sort of, be humbled to the fact that what I went through was my journey, and as painful as it was, I'm so incredibly blessed and proud to be here. And so with that, I want to open up our panel discussion. And I want to do so by having everyone on this stage introduce themselves, tell the audience a little bit about who you are, the work you're doing, and then why you're here tonight.
Really so thrilled to be here with you tonight. My name is Kristine McWilliams. I am the medical director of genomics for CooperSurgical. And by training, I have an MD and a PhD, which sounds probably pretty impressive, but really it means I just couldn't decide what I wanted to do with my life. So I went to school until I was about 33 years old. Don't recognize. But in any case, what kind of sent me down that path? You never know when something's going to happen that absolutely changes the course of your life. And for me, it was when I was doing my undergraduate studies, the human genome was published. And just the incredible power of opportunity that afforded. I knew that at that point, that's why I wanted to dedicate my career to, was to try to use that information to help people have healthier lives to the best of my ability. And I have been in the field of pre-implantation genetic diagnosis, which is very long term, and we'll probably get to a little bit more about what that is. But I've been in that field for 10 years now. And what that field is dedicated to doing is to help families that know that they're at a specific genetic risk for a disorder such as BRCA, to empower them to say, I'm going to do something about this for my children and the generations to come. It's a test that essentially through IVF can help families avoid passing those genetic risks down to their children and ultimately their grandchildren and so on and so forth. It's really just been an honor for me over the past 10 years or so to be in this field. And absolutely, without a doubt, when I look back at what we were doing this test for when I started and what we're doing it for now, the top change has been the number of families coming to us specifically for avoiding passing on cancer risk genes to their children, and specifically BRCA is absolutely the most common one we're doing these days. And it really is an honor to try to help folks specifically with the disorder. That's my cancer story. So thank you very much.
Hi everyone, my name is Caitlin. I'm a BRCA2 mutation carrier. I'm a breast cancer survivor at 29. And I have two children with the help of Dr. Lederman who are not BRCA2 mutation carriers. I do not have a PhD. I have a master's degree, and I'm here to share my story with you guys a little bit later on, and kind of all the prevention that I did to get to where I am today, and how I learned about genetic IVF. So that's my story.
So it's truly an honor to be here tonight. My name is Dr. Matthew Lederman, and professionally, I'm a fertility specialist that's part of the RMA New York Westchester team. Personally, I am the husband of a BRCA2 carrier. So the way my wife's story goes is that shortly after we had our son, our second child, we learned that my mother-in-law, who's also here in the audience with my wife, tested positive for the BRCA gene mutation. Not long after, my wife underwent testing and she came back positive. And at the age of 33, she underwent a prophylactic mastectomy and reconstruction. At the age of 40, we decided that our family was complete, with 2 kids, and then she underwent a risk-reducing surgery to remove her fallopian tubes and ovaries. And I have 2 kids. My wife and I, we have 2 kids. My son is a freshman, sophomore in high school, and my daughter is a freshman in college. And they each have a 50% risk of inheriting the gene and the risks that come along with it, which you'll hear about tonight, and all the scares that it could bring along with it. So this is a topic that's extremely near and dear to my heart, because of what I do professionally, but also how it affects my family. So what I've tried to do is be a big advocate for the hereditary cancer community, which includes BRCA carriers.
Hi, my name is Stephanie Bernik. I am Chief of Breast Surgery at Mount Sinai West in New York City. I also run the fellowship program there. And I am here because it's Breast Cancer Awareness Month, but more importantly, it's really to have a conversation about breast cancer risk and what you can do if you are a BRCA carrier. I work very closely with plastic surgeons. I'm very happy about what we can offer women. It's so much better than when I even started in practice a little over 20 years ago. And I started doing breast cancer surgery just because I love the interaction that I have with patients, because there's very few fields where you get that close with your patients. It's really intimate, and I'm honored that patients will come and sort of, they trust you openly, and it's they sort of give themselves over to you. It's really it's an honor, and I'm very happy to be here to talk about it.
Hello, good evening. My name is Valentin. I'm a gynecologic oncologist. What that means is I take care of women that have gynecological malignancies, which include ovarian cancer, uterine cancer, and so forth. And a big portion of my practice is also seeing patients that are BRCA positive through their journey and preventative care till they're ready for their risk-reducing surgery, which will include removing the ovaries and the fallopian tubes. And by that means reducing the risk of developing cancer in the ovaries. And I like what I do, and I'm happy to be here and answer any questions that you might have further.
Let's dive in. All right, so here we go. Dr. Williams, I'm going to start with you. If you'll just sort of simplify and keep it simple for everyone in the audience, why don't we break it down? What are BRCA1 and BRCA2? And if I test positive, what does that mean for my risk of breast and ovarian cancer? We talk a lot about breast cancer, but for both.
Absolutely, yeah. And I promise I'll keep it far shorter than my educational journey. So, BRCA1 and BRCA2 get kind of a bad rap. I mean, what they essentially are is they're genes. They're a part of our genome, 2 of the over 30,000 genes that are within the human genome, and they have a particularly important role for us. They are a type of gene that actually helps to protect our genome, helps to, if other errors or mutations, you may have heard that word, if those occur, then these genes, when they're functioning properly, fulfill an important role in protecting the genome, helping correct those errors, or helping make sure that cells with those errors don't grow and make other cells. And so it's a real problem when those genes are not functioning properly, which is exactly what happens when there's a BRCA1 or a BRCA2 mutation. They don't work well, and then that allows there to be more genetic changes that happen to cells, and those cells can become cancerous. And what the risks are is when they're not working well is quite staggering, right? A woman in general will have a 1 in 8 or 13% chance of developing breast cancer within her lifetime. If a woman has a BRCA1 or BRCA2 mutation, that can go up to 70% risk, which is really staggering. And that risk can apply to both developing breast cancer as well as developing ovarian cancer. And I think really underscores the importance of doing the genetic testing if there is a known family risk to understand if one of those mutations is present.
Absolutely. I think for me, when they sat me down and the doctor showed me a chart. I mean, Mom, you remember you were there with me, and it was, your age and then your risk. And my risk for breast or ovarian, I forget which one, was almost 44%. And the doctor was like, I'm actually surprised you haven't gotten breast cancer yet. I mean, it was staggering that I didn't know this, and I was walking around with almost a 1 in 2 chance of getting breast cancer. But I want to just turn that a little bit to what we were talking about a little earlier, Dr. Lederman. How much I worry about my kids' future and what this means for them. They're 7 and 9 now. I was told they get tested, or they should be tested when they're 25 years old. I would imagine you promised me that the medical technology was going to change by then, Dr. Bernik. But if it doesn't, when should children get tested if they are children of BRCA carriers? And what are the chances? What are their options now, knowing what you have to go through a little bit later?
So when it comes to getting testing, first of all, the 50%, as I mentioned before, of the offspring are going to be affected. So obviously that's high risk. Obviously, when it comes to getting testing, there's no reason to test when they're young, because nothing to do about it. It's when the breast and ovarian cancer risks start to increase, which starts around the mid-20s. So usually most if they choose to get tested, once again they have to choose to get tested, is around the age of 25. And then they have the options. There's the options of prophylactic surgery. There's the options of periodic monitoring, and imaging of the breast. When it comes to ovarian, there's not great monitoring. There's ultrasounds one could do. There's certain blood tests, but there's not great monitoring for ovarian cancer. And I'm sure Dr. Kolev will talk about that, and Dr. Bernik will talk about monitoring for breast. Since there's a 50% chance of passing on the mutation, some couples will choose, like Caitlin will talk about, the option of pre-implantation genetic testing or diagnosis. There's different terms for that. It's a special form of IVF. And before even doing the IVF, one needs to build a special DNA marker, DNA probe for the mutation. It's done by a specialized genetics laboratory. It takes a few months. Often requires a DNA sample from the patient, from the partner, sometimes even additional family members. Then one undergoes the IVF. And when we do IVF for all our patients in this day and age, we don't transfer back the embryo right away. We biopsy and screen the embryos for chromosome abnormalities such as Down syndrome. And so in these cases, we not only could check for chromosome abnormalities, but we could also check for the BRCA mutation. And that then allows the couple to end the BRCA cycle in their offspring. So they could choose to end the BRCA cycle so their children don't have to deal with that.
Okay, and we're going to get into a little bit about the work that you did with Caitlin, but I want to take one step back first and talk about how, Dr. Bernik, we assess our risk for breast cancer. What type of screenings are available? How often should someone be screening?
We usually start screening around the age of 25. We start doing MRIs in young women. We wait and hold off on mammograms till the age of 30 because there is a small risk of radiation exposure and a theoretical risk that if you have this gene, you might be more susceptible to the bad effects of radiation. Having said that, radiation from a mammogram is really low. If you fly from here to LA, you get more radiation than you do from a
I don't think people
mammogram.
realize how low it is.
Yeah, so, I'm not that concerned about it, but we standardly wait till 30. We do MRIs and we alternate that with ultrasounds every 6 months. Once you hit 30, we're still doing studies every 6 months. Some people do MRIs every 6 months, some people do it once a year. There is a risk with MRIs. The dye we have found can accumulate in the brain, so no test goes without some risk. They don't know it's this gadolinium can be seen years later in someone's brain, and they don't think it's harmful, but they don't know. So, we're careful about our studies as well. So that's screening. The ultimate treatment would be, having surgery, which I think we're going to talk about later.
We are.
Yeah.
Thank you. Dr. Kolev, my biggest stress during my BRCA journey was the what next question. Because, just listening to everyone up here, it just sounds so overwhelming, right? The word mastectomy sounds just terrifying. So how do you help patients sort of navigate what the next steps are once they receive either a BRCA or a breast cancer diagnosis?
Well, we talk about the risks that those bring specifically for my field for ovarian cancer, and that is associated with a big portion of fertility in the fertility plans, and when their childbearing is going to be completed. And in terms of screening, we do ultrasounds every 6 months, no radiation, but unfortunately they're not great for diagnosing potentially early or catching early on ovarian cancer, but we don't have anything else, so that's what we do. And I talk to my patients that, we recommend removing the tubes and the ovaries as soon as childbearing is completed or by the age of 40. That being said, there's a lot of data lately, and me personally and a lot of people in my field, we believe that most of the ovarian cancer actually starts from the fallopian tubes, not from the ovaries. And part of what we started doing in part of clinical trials is just remove the tubes and delay removing the ovaries so we don't impose the menopause and all the consequences of menopause early on. However, unfortunately, that data is still not up to date. So we don't know actually how much that decreases the risk, but I think it's something that is going to be in the near future and, be very different, not putting women to menopause, and if you just remove the fallopian tubes instead of remove ovaries in that regard.
Yeah.
Did you know about that?
Nope. Nope. Did not know that. I walked out of my hysterectomy. They're like, "Welcome to menopause." I'm like, "To what?" What's the return policy on all the things they took out? Like the fallopian tubes, the uterus? No. I actually didn't realize there was so much involved in a full hysterectomy. And I already had kids, and so they were like, "We're going to take this out and this out." I was like, "Leave me something." Like, do we barter? There's no bartering. Dr. McWilliams, let's talk about getting screened for the BRCA genes. So specifically talk about, how does CooperSurgical specifically address breast cancer screenings, BRCA screenings? Talk to me a little bit about that.
At CooperSurgical, we don't actually perform BRCA screening on adults directly, but we do intersect with it in a couple of ways. We've talked a little bit about the pre-implantation genetic testing that we can do on embryos to take that that risk from a 50% chance of having maybe a 70% chance, lifetime risk of breast cancer down to the much lower. In genetics we never say no risk because there's that doesn't exist, but down to that closer to that at least that 1 in 8, the 13% or lower. But one of the roles that I play at CooperSurgical is I'm the head of our genetic counseling department. And we have a large team of genetic counselors, and we take every opportunity we can when we speak with a family, even if they want to talk to us about something completely different. Not breast cancer, not cancer at all.
The Celtics.
Yeah.
Anything.
Yes.
Yeah.
We're going to respond and say, I think they're having a great season. Let's talk about your family's cancer history. Okay. Because we know that it really starts with that history, right? BRCA1 and BRCA2, yes, they're the genes that we know the most about with breast cancer, but they are not the only genes that are involved with that disorder. We're learning more and more genes are contributing to breast cancer. And so we always need to know what is that family history, what types of cancer run in your family, because it's not just a question of whether there's going to be a recommendation that you should consider genetic screening, but also what type of genetic screening. Are we really just targeting BRCA, or maybe we need to look at additional genes as well?
It's a very thorough process. The questions about who in your family might have had. I had 137 calls to my parents just having when I got off with the genetics department. But then it was a simple saliva test. For anyone that doesn't really know, it's a simple saliva test to really get so much insight into what could be the next direction your life is going to take if anyone is worried about what the actual test is, right?
That's correct, yes. Where we're at with the technology of genetics these
Right.
days, the technology is now actually what's easier. It's the knowing what to look for, where to look, what test to order, which is what elicited all of the phone calls.
That's what you had I just had to spit. So for me, it was really just, bleh, and that was how I learned all the information you did. All right, Dr. Lederman, I want to talk about you and then about Caitlin's journey as well. I want to hone in a little bit on fertility because it's important. Because I had my kids and it was a no-brainer. It was a full hysterectomy, let's go. But a lot of people are faced with this and do want to have children. How does RMA of New York work together with oncologists just to make sure that patients are getting everything they need, their options, their timely treatment, and obviously the ability to preserve their fertility?
So when you look at someone who is actually diagnosed with breast cancer, just starting there, oftentimes they require chemotherapy as treatment. And chemotherapy is extremely harmful to ovarian function. And because it's harmful, that could either put them in a menopausal state, or even if they're not menopausal and they still get periods, it still affects their fertility. So oftentimes we'll work with the breast surgeon, the gynecologist. We get the patient, bless you, right away. We get him started to, in a fertility preservation cycle to freeze eggs or embryos. It's safe to do. It takes about 2 weeks, and then they get on to chemotherapy. So that's looking at what we could, how we help patients who are diagnosed with cancer before they start, chemotherapy. When you look at the other side of that is, someone who's a BRCA carrier who doesn't have cancer but is a previvor. And that, fertility preservation sometimes doesn't get enough attention, for those patients. And, Caitlin will go into that. And the reason fertility preservation is important is that BRCA carriers are not only faced with increased risk of breast and ovarian cancer at a much earlier age of onset, but they're because the risk of these, breast ovarian cancer at much early age of onset, that's where fertility and family planning is a major concern for many of these women. And that's where one has the option of preserving fertility by freezing eggs and embryos. And BRCA carriers are faced with unique issues related to thinking about starting a family. For example, if or when they plan to undergo a risk-reducing surgery to remove the fallopian tubes and ovaries prior to either starting or completing a family. And these women have the option of freezing eggs or embryos before taking out the tubes and ovaries. And one does not need ovaries to get pregnant. If they freeze eggs or embryos, we could give them hormones to support the early pregnancy before the pregnancy itself takes over. Other factors that may affect their decision is that, as we said before, 50% of their offspring will inherit the gene, and that plays a role in terms of how they think about their family. Another factor that may influence their decision is that there have been multiple studies that show that BRCA carriers, and this is a little bit more BRCA1 than BRCA2, have made decreased fertility, decreased fertility potential. They have lower fertility markers and may not respond as well, to fertility treatments. Not all studies show that, but there are some studies, and I've seen patients with BRCA who have normal fertility testing and others who have lower fertility testing, as Caitlin will share. Other factors that play a role is how old they are. Age plays a role with all natural fertility, but age plays a major role in the success of fertility treatments. Another factor that may influence their decision is whether or not they're single or married and how big of a family they ultimately desire. So BRCA carriers are faced with these unique challenges when it comes to thinking about starting a family. And because of that, it may make sense for them to meet with a fertility specialist when they're diagnosed with the BRCA mutation. Oftentimes they're referred to a breast surgeon, a gynecologist, but also makes sense to meet with the fertility specialist to learn about their reproductive options, what options they have given their situation and what they desire. And for women who are committed to do the special IVF to screen out the BRCA mutation to end the cycle, it may make sense for them to freeze eggs or embryos at an earlier age. And the reason for that is the younger they are, they're more likely to get more eggs, and they're more likely to get eggs that result in chromosomally normal embryos. Because 50% of all the chromosomally normal embryos are going to be affected. So you lose 50% of the embryos. And because of that, if they want to set themselves up for success, so if they're committed to doing fertility treatment to screen it out, I really encourage women to do that at an earlier age, to freeze eggs or embryos, because they're more likely to get more embryos that are chromosomally normal and BRCA negative. And a chromosomally normal embryo implants at about a rate of 60 to 70%, so they could set them up for future success.
It sounds so complicated to me, and I went through a big portion of it, right? If I was, if I had all this laying ahead of me, I would know where to go or where to start or how to start or if it was worth it. And it just feels like such an overwhelming process, but how lucky that we get to sort of pick your brain and you've broken it all down. First of all, so proud of what you've gone through and how you handled it and all the choices that you have made, and you have 2 beautiful children, and you beat cancer, and you did so many things. And how many burpees can you do? You just done so many great things. So many great things. Caitlin, talk to us a little bit about how you educated yourself, how you advocated yourself, and then just give the audience a little bit of a background about your story, because I can't imagine you're the only one here that has or knows someone that's faced with what you were faced with.
So I have quite the story. So I was diagnosed at 29 with stage 0 breast cancer. I screened at 25. The breast cancer comes from my dad's side of the family. So everyone's like, oh, it must, come from your mom's side. And something that we talk about is that, you have to check your father's side as well. So on my father's side, we had lots of women who died very, very early, late 30s, early 40s. So we actually had a family member in the 90s after the BRCA mutation was discovered, and she started the cycle, and she was like, something's wrong here. And she got tested, and she found out she was a BRCA2 mutation carrier. So that opened the door for so many people in my family to be like, hey, we need to get tested. So I pushed my dad, because my dad is, a typical male, and he was just like, oh no, it's fine, there's nothing wrong with me. So I pushed him. He has 3 daughters, and he came back positive for the BRCA2 mutation. And out of his 3 daughters, I was the only one who actually was a carrier. So 1 out of 3, it's not so terrible, but I was the one who got it, which was fine. I started at 25, I went for all the preventive every 6 months. You heard the stories from the breast surgeons and everyone over there, and I was able to catch it at stage 0. It was in the duct. I went for the bilateral mastectomy at 29, and before I went for the mastectomy, I actually met with Dr. Lederman. So I did not know anything about genetic IVF. I had no clue what it was. I was in my surgeon's office sobbing and telling her, after this screening, I was going to start my family, and she's like, oh my gosh, you have to check out genetic IVF. I'm like, what is that? And she gave me the information, and I went to my plastic surgeon, and he actually had ties to RMA. And I called Westchester, and I got paired with Dr. Lederman, who, in the full circle of things, has history with his wife and his family, so it was almost like meant to be. And so I actually met with him before I got the double mastectomy, and I did all the tests, and I found out I pretty much had low ovarian function, which, Dr. Lederman kind of touched on, could be attributed to the BRCA2. My reserve was not great, or anything like that. So we started cycles, and it was this 3rd cycle that I was able to get my 2 children today. I didn't really believe in myself as much as Dr. Lederman believed in me. But it was a tough road, but it wasn't until I actually met with my surgeon did I even know about genetic IVF. And that is something that, to Dr. Lederman's point, when I was 25 and I found out I was a mutation carrier, I wish I froze my eggs, because then at 30, once I did start the actual IVF, my eggs could have been in better shape. I could have had more of an ovarian reserve. So that is something I wished I would have done, and I hope people learn from today.
I feel like people go back and forth on whether freezing eggs is the right idea or not. I've heard both, and I've read both. Is there a definitive answer, Dr. Lederman, or is it circumstantial?
Well, eggs in this day and age are almost as good as embryos. Embryos are a little bit better, but it depends on their situation. If someone doesn't have a partner, it may make sense to freeze eggs. If they have a partner, it may make sense to freeze embryos. That's why it's so unique to their situation.
Right.
And as Caitlin said, she didn't know about this. I remember her saying, "I wish I knew about this early on." And that's what I've been trying to be an advocate for is, when they
You
get
know about what
diagnosed.
freezing eggs and, okay,
Yeah.
planning for the future.
Exactly.
I interrupted you
Oh.
completely.
Oh.
I'm so sorry.
That's all right. I'm used to being interrupted. My son does it all the time. He's much older.
Okay.
But no, so when they get diagnosed, they go to see a breast surgeon, they go to a gynecologist, they should really meet with a fertility specialist, even at age 25, just to understand what their reproductive options are, so they can pair themselves to make a plan, to know what their options are. And everyone's going to choose different options. There's no right or wrong options. It's what option makes sense for them in that situation, and that could change with time.
Right. Dr. Bernik, I want to turn it over to you. Having breast cancer surgery following either a BRCA diagnosis like I did or breast cancer, you hear it, it's such an emotional journey, and I'm sure patients come in all the time and you hear everyone's story is a little bit different. For you, for your family, for your children, for the people all around you, how do you help patients navigate their way through what obviously is a very, very challenging time?
So I think it's important for patients to know they're not alone, and there are plenty of support groups. My office and myself, my nurse, my PA, we try to help patients. We're very open to questions. But we're only in the office. They're going to need help at home. We have a social worker that can set them up, tell them about groups that are available. It's important to I tell patients they have to open up to their family, because I think family and friends, you have to turn to the people that are with you all the time. A lot of people want to keep it as a secret, and I think that's worse. I think it becomes more of a monster. I think if you can openly talk about it, and get your friends' support, your family support, it really makes the journey a lot easier. They play a key role in any sort of diagnosis, whether it be for cancer or knowing about a genetic mutation before you even have an issue with cancer. Their input is really going to mean a lot.
Why do you think that is, that people are worried? Is there a stigma around the BRCA gene, the mutated BRCA gene? Is it it can't be the breast cancer. Every other month we celebrate it, we talk about it. We put it out there because we want people to talk about it.
I think a lot of these women are young, right? So they're dating. How do I tell someone that I have this genetic mutation and I'm going to ultimately take off my breasts and not potentially be able to have children? If I have to take my ovaries out, and it sometimes it's blown out of proportion because they don't have all the information. So it's important to get educated, have the information, but I think they have to try to at least get the people closest to them to have them there, to just have a discussion with them and be able to go to them when they're feeling down about it. It's normal to not be happy about having this gene. People are angry. There's the why me, and I say the same thing. I don't know. Why is it you? It's not fair, but it's there. The good news is there's a lot we could do about it, and a lot of what we can do now is really positive. So that's coming from my standpoint, what I try to tell patients. It's not great to remove your breasts. It's not great to remove your ovaries, but at least you can take control. Sort of what you said. You have to, feel empowered and look at it from that angle. Like, I'm going to take control. I can freeze my eggs. I can have a child even if I have to take my ovaries out. I can have great-looking breasts even if I have to remove the ones that I feel. I can at least look like a woman and feel really good about it.
I look like a woman and feel really good about it. Dr. Kolev, I want to thank you. We all do. You do too, Dr. Kolev. You look like a woman and you feel really good about it. I didn't want to leave anybody out. You too, Dr. Lederman. I want to ask you the same question. You have such an easygoing, sort of like laid back nature to you, but yet you have patients that you see and who are facing what could be days, months, weeks, years ahead of them of what could be like mine was kind of a tough journey. How do you speak to them and talk to them about keeping everything sort of in perspective because it is going to be a bit of a journey?
Well, again, it's the same thing. I think the most important part is educating your patients. And, you know, I see some of my patients for years. I start seeing them in their 20s, and then I talk to them how they need to consider risk-reducing surgeries by the age of 40, which is somewhere 15 years in the future. But, you know, I try to talk to them in terms of, you know, you have time and you have to be proactive about the things that you do and make a plan how you want to do this. And sometimes, you know, they're young women that are, you know, not even in a relationship, and then I make sure that they go and strongly consider freezing their eggs. And I talk to them, it's like an insurance policy. You don't know what life will turn around and what it will do. And we meet every 6 months and we go over again.
See, I told you, he's so laid back. I'm like, I don't even need it. I'll see you in 6 months. But I think what you said is the key, and it's the plan. And I remember I sat down and we had to write a whole plan of what was next, and we looked at the calendar, and you just do step by step by step. And I think that's the way to do it, and that's how to keep it from becoming so overwhelming, because it is if you're freezing eggs, if you're talking about fertility. But Dr. McWilliams, what are your options, though, but managing a cancer risk? So now you get a cancer diagnosis. I would imagine it is just so overwhelming for a lot of people. How do you manage those risks? How do you start setting up a plan for people?
I think on the genetic side, you know, to some extent, once the genetic diagnosis is made, you know, that work is kind of done, right?
Done.
So in terms of a plan, I think, first of all, the thing that, you know, we encourage is please talk to your family. You know, please, you know, let siblings know in particular, you know, of your diagnosis. Please try to find out more about the family history and the, you know, and if there is cancer, you know, what was the type? Did anybody else find this? You know, really, it really becomes, you know, let's start a dialogue about, you know, about what you found out and what your options are, knowing that, you know, when it comes to the genetics, there's still something that you can do. You know, even if perhaps your family, you know, building is done, perhaps your siblings are not, or, you know, and then there's other generations to think about. So please start a conversation with your family, so that we can empower not just yourself but everyone.
Caitlin, did you find that was helpful? Did you have to, I mean, you talked about walking in and just crying, like, what do I do? And I know that feeling. It's, what do I do? I also know the why me. I mean, I think anyone that has been through it really gets it. I'll call back. Can you just talk a little bit about that? Because you just got over all of it. Did you set up a plan, and how were you able to, at some point, compose yourself and say, okay, there's no joking around. Like, I have to do something now, and here's what it's going to be.
Yeah, so I remember walking in at 25 to get tested, and the doctor's like, are you mature enough to know this information?
Oh,
Dead serious, that's what the doctor told me.
wow.
And I was like, obviously I'm here, so yes. And, you know, yes, we did set up plans. I'm very proactive about my health. You know, I made sure I was in my OBGYN's office. We had this every 6 months. I was getting screened, everything. What caught my cancer actually was the MRI with contrast. It was not a mammogram. It was not a sonogram. It was the MRI with contrast that caught it. And I remember coming across this quote, and I'm probably going to butcher it because I'm up here, but it was like, you don't have the right to believe in the cards you should have been dealt. You have an obligation to play the heck out of the ones you're holding.
Awesome.
And that kind of just really stuck with me. So my first card was knowledge. I know I'm a BRCA carrier. What are all my risks? My second card, prevention. Going every 6 months, making sure I'm getting screened, and in case, God forbid, something shows up, which unfortunately it did, we catch it early. I had no chemo. I had no radiation. It was straight to the bilateral mastectomy. And reconstruction in the same surgery. So I was in and out in one surgery. And then my third card was the genetic IVF. So what am I going to do to protect my future, which are my kids? I am the only person in my family that has explored genetic IVF. There are other carriers, and I've been very open to them about it. They don't have children right now, but that's what I kind of really focus on was a genetic IVF card. Thankfully, so on my family tree, my dad was a carrier, I was a carrier. So now I kind of say like all the limbs are now, the new growth is clean. It ended with me, it's gonna stay ended with me. And it's kind of great, thanks, to RMA and Dr. Lederman. My son is 18 months now, my daughter is 4, so that's kind of that. And then I just continue my cards, prevention. I've got the ovarian, risk, and we will be exploring, the hysterectomy by 40. And just telling my story, sharing it to whoever wants to listen. And that's kind of how I've done how I advocate for myself.
It's the most important thing you can do is just talk about your story, because if you went through it, there's someone else that went through it, there's someone else who knows someone who went through it. I'll admit I didn't know anything about BRCA until my mom tested positive, and she's like, you should get a test. I was like, test for what? She's like, BRCA. And I remember saying, how do you spell that? Like, I'm a woman in my 40s, and I didn't even know what BRCA was. Like, how was I so uneducated about this? And then having to undergo what I did the last 8 months, I know so much now, and you almost want to talk about it. You want to tell people that there are so many options out there. What, Dr. Lederman, is the biggest question you get with regards to fertility, whether you're a test positive for BRCA or you're a cancer patient? What are some of the biggest questions you get that maybe people here in this audience have tonight?
It's very unique to their situation. Some, as Caitlin, she wanted to do the genetic IVF and eliminate it. Not everyone chooses to do that, And whenever I see a new patient, I always take a detailed family history, especially when it comes to cancer history. And oftentimes you'll find, a fair amount of cancer in the family, and we talk about potentially, cancer genetic testing, to rule out. It's not just the BRCA gene. There's other genes, that Dr. McWilliams said before. It's a cancer panel now. And oftentimes patients are so focused on fertility that they say, I'll hold off on that. I'll deal with that later on.
Yeah.
Because they just want to get pregnant. They've been trying for so long to get pregnant. Their focus is on fertility, and they often put that off. Some will choose to go get screening, but oftentimes they don't. What I've been one of the things I've also been trying to advocate is and many of our patients are a lot more familiar with this, but more doctors are starting to ask about that when they go to the OBGYN, when they go to internists, about cancer history. And that's ideally when that should come up. They should, if they're interested, go get tested. And they would come to us already knowing that information. Because by the time they come to us, when they're talking about fertility, most of them don't want to address it. They want to hold off because they're just thinking about, I just want to get pregnant.
Are the majority of your patients younger, are you finding now? Are you having to have these conversations? I mean, I have to be honest, I didn't really fully understand. Did you, Caitlin, understand the whole scope of what options were available to you? I mean, I walked tonight into this meeting with all of us not knowing, I was like, how are my kids going to be able to have children if they are at a 50% chance of being, I mean, I really didn't know. Are you surprised, I'll ask you, Caitlin, are you surprised that the people around you don't know as much about everything you've just gone through? Because I know that I was.
I mean, I was too. I mean, I literally educated my OBGYN on genetic IVF. So
Say that again. You educated.
I came back to her and, I said to her, listen, I'm doing genetic IVF. And she was like, what is that? She had not a clue.
Wow.
So yes, I do find that. And I do constantly speak about it. So even if in conversation, because people are like, oh, you're going to go for the third? And I said, well, I went through genetic IVF, and I kind of tell them, like, wow, I never even known that.
Right.
So yes, I'm not shocked either.
Dr. Bernik, I know we talked about this a little bit inside, and I'm going to put you on the spot again. Where is the future going now with regards to what options my children have? And they're young. I know you're taking it away because you're going to tell me that we are going to fix it and solve it and be able to fix. Okay.
So I'm very optimistic. We were saying this.
You were so optimistic.
Yeah,
I love that.
Yeah, we've come so far in the. I started doing this like 23 years ago, And we have come so far from when I started. Things are changing, and it's not exponential, but it's at a much faster pace than it was changing, even 10 years ago. I feel like every few months there's something new. I mean, we're backing off of the axillary surgery we do. We used to, when someone had breast cancer, we would, do the breast and also look at the lymph nodes under the arm. And very often we had to do something called an axillary dissection that put someone at risk for permanent swelling of the arm, lymphedema. Well, in the past few years, we're doing so much less axillary surgery. We just take out a few nodes, but even if those nodes are positive, we're often not going back to take more nodes, which was the norm. So my feeling with where we're going with genetic mutations, I am sure, pretty sure, that
She went from short to pretty short in less than a second.
in 10 to 15 years, we are going to have a way to fix these things, or at least make them better. But already, we're able to eliminate the embryos that potentially have it. And that's not right for everyone, I know that. But for the people that want to do that, we have that technology now. I think going forward, we are going to be able to fix things. I mean, that sounds far-fetched, but 10 years ago, we would have thought doing what you do today is far-fetched. So I think that's where we're going. How do you feel?
Well, I agree. I think the thing, especially in the last 10 years, and in terms of the immunotherapy and immunomodulations and targeted therapy, the things have changed so much in the field of cancer that I don't see why not. It cannot feel in the way of fixing the defective genes. I mean, the reality is that the BRCA genes, they're very important. They fit the DNA, and just when they're not functioning well, they just don't fix it, and that's how the mutation appears. And yeah, I think it can totally fixable.
Okay, totally fixable. We'll all sleep better tonight. It's totally fixable. No, I'm so encouraged. I really am. I mean, look, I had it. I have 2 little girls. I think about it all the time. Dr. McWilliams, can you talk a little bit about what you see as the future of genetic testing?
I think to some extent we're kind of living the future, and not only do we have the genetic IVF, but already we mentioned the tailored therapy. The therapy gets tailored on the basis of the genetic testing of if not the individual, certainly the cancer cells. So we're already doing quite a bit to use genetics to target therapies, make them as effective as possible. I am not as optimistic that we're going to be able to fix the genes within 10 to 15 years, but but you never know. I do think I do think and hope though that really even before that there's a cancer moonshot that's going on right now that the White House is pushing through, and and I think that what is actually it should be accessible to all of us today is the testing. If there's a risk, if there's a family history, the access to the testing needs to be better.
Is it not? Is there a BRCA test, or is there a genetic test available to anyone who wants it, or how does that work?
Well, I don't know if it's as dire as, the number of OBGYNs or internal medicine, docs that know about genetic IVF, but I don't know that there's a lot of comfort with primary care physicians to say, let's do a cancer history, let's go through your cancer risk and let's assess what the appropriate next steps are for you. There's definitely too limited of access to genetic counseling, so that individuals can actually have a dedicated session to talk about those risks and get access to the testing that really could highlight their risk or maybe put their mind at ease. So I think we actually have a lot of tools that are available to us right now that I think we could certainly do a better job of using while we're trying to figure out how to fix the gene. And there's definitely work ongoing there.
Well, I think one of the questions I get all the time is, well, can I take a BRCA test? Why can't I take a BRCA test? Do I just call my OB and take a BRCA test? I want to take a BRCA test. BRCA test. Sound like Seinfeld. But that's what I say. Is it open to, can anyone take a BRCA test, whether you have cancer in your family or not? Maybe a lot of people don't know. how far away are we from that being an option that your OB or your primary care physician offers to you?
So we are actually there. If somebody really wants a test, they can have a test. But the issue becomes, not to say that, certainly a 25-year-old is able to receive those results, process those results,
Sure.
especially with, a family history and
Caitlin
family.
can't, but everyone else
Yeah, exactly. You set the bar high for
Right.
25-year-olds. No, but I think it really is important to have a plan in place of, what if something comes back positive? And, as the testing nowadays, we talk that it's mostly panels now. Well, the more things you add to the panel, the more likely that you're going to come back with something. And it's not always a yes or a no. A lot of the results now are maybe, right? And in particular, I think it's really hard to know what to do with the maybe results. And so for that reason, I do recommend that you do have a healthcare provider that you are planning to discuss the results with.
And then let's round it out, if Dr. Lederman, you want to chime in just on where you see the future of the work that you're doing. I mean, Dr. Bernik said she 10 years ago would have been, impressed with what you're doing today. Where are we 10 years from now? She's really impressed with you.
I think we're not quite there yet in terms of eliminating it, which that'd be amazing, whether it's a vaccine, whether it's something like, I think there's studies going with the vaccines looking at BRCA carriers. But until we get there, there's things that we could do now to maximize the future. I think one thing that's needs is just empowering with information, and a lot of people don't realize how common the BRCA mutation is. That's one thing we haven't quickly spoke about. But 140 Ashkenazi Jews are a carrier compared to 1 in 200. That's a lot.
1 in 40.
1 in 40 Jews are a carrier, compared to 1 in 200 in the United States. That's a pretty high, that's a lot. And I think just getting it out there so people are better educated and then can make informed decisions, And until we come up with a vaccine, there's things, women could do proactively. And men have also been neglected a little bit when it comes to the BRCA gene, as Caitlin said. Yes, they may not be as risk to cancer. There's the risk of male breasts, pancreatic, melanoma, metastatic prostate, but it's their daughters. 50% of their daughters will have to, go through those scares of everything.
Right, I didn't even know that men were testing positive for BRCA. I had no idea. Okay, we just threw an enormous amount of information out at you right now. I would imagine we answered a lot of your questions, but we wanted to make this a conversation and involve everyone. So if anyone does have a question, let's go. Let's feel free to address anyone on the panel, except for me, because I don't know that much.
Hi. My name is Lauren Tenbaum, and I'm a social worker and a writer focused on empowering women. So I just want to clarify, what is the message that the average woman should know when it comes to requesting testing? Should they go to their primary care physician and say, I just want a test? What's the language that we're using? And then the second part is sort of an observation, which is that this can all really be probably very expensive, right? The genetic counseling, et cetera. So if we could hear about any resources, that would be wonderful.
I'm not advocating for 23andMe, but 23andMe does check for BRCA pretty accurately, not as good as it should be. I'm not advocating.
Checks for the 3 Ashkenazi Jewish mutations.
Yeah. So yes, it's pretty accurate for that, but that's like a general screen. However, real genetic testing can be done in your doctor's office, and usually the cost is about $200 to $250. So some people can't afford that, but some people can, and if you can ask for it. Insurance covers it if you have a family history. If. So if you don't have the family history, if it's coming from your father's side, there may be very few women there may be very few women in that family, and you don't see the cancer so much. But they will often cover it when it's indicated. But if you don't have a family history and you still want to get tested, you can pay. It used to be $4,000, so it's like when I started. But now it's more affordable, and you know, you're not gonna get funding for someone that, where it's not indicated, where when you go to a doctor, they really wanna do things that are indicated, so we're not advocating mass screening. But if you really just feel like you wanna know, you can pay.
I'm Nancy Cohen. I'm a cancer genetic counselor working in the Westchester area by telehealth. But in any event, what 23andMe does is they check for the three common Ashkenazi Jewish variants or mutations in the gene, and that's it. So it's a completely irrelevant test if you're not Ashkenazi Jewish, and if you are Ashkenazi Jewish, it's an incomplete test because we know somewhere around 5% of Ashkenazi Jews will actually have a mutation outside of those three. So I just get wary about thinking about 23andMe in the same way that we think of these multi-gene tests, which are actually sequencing. Think of it like spell check, the whole of the gene, and then also looking for big chunks of the gene that are duplicated or deleted. And actually the NCCN, National Comprehensive Cancer Network, now does say that for Ashkenazi Jews, even if there is no family history, you could consider genetic testing. I don't actually know whether insurance, kind of buys that or not, but I try it for patients to say, the guidelines say
They
consider.
don't buy it. They don't. It's, unless they come out and they say absolutely it's like indicated, insurance companies just try to, I have patients where it's indicated and it's still not covered, but most of the time, when there is a family history, certainly if they have a diagnosis of cancer, it's covered. But it's more of an issue when the patient doesn't have a diagnosis of cancer. They look for more reasons to potentially not cover it.
I will say you're correct, yes, on the Ashkenazi, that's what 23andMe is mostly known for, but they just got FDA clearance for 41 additional variances. So that is better because the everyday consumer or individual who's going for that testing, that seems more attractive to them, right? Especially when they do like a Black Friday sale for $59 on Amazon versus going through your, regular clinician or genetic counselor or geneticist to get testing through like say Invitae or Ambry or one of those more reputable organizations that have the panels. That is definitely something that I think we need to educate more on, like what genes are we testing for and what mutations are we testing for and what is your risk. So I thank you for bringing up that point.
Hi, Alana Zimmerman. I'm a Previver as well. I did not have BRCA. I had CHEK2, and for 2 minutes I'll tell you my story because I think it's really important for everyone to hear. My mother had breast cancer at 40. She did not have BRCA. I had 2 babies, and at 37, my best friend told me, well, there's all these new genes. She's also a survivor. So I got tested and found that I had CHEK2. My breast surgeon told me, nothing to do about it. We don't really know the risk, blah, blah, blah. And this was during COVID. So a year ago, I had my first MRI, and I was like, screw this, sorry. I was like, I'm not living with anxiety every 6 months. So I decided to go ahead with a prophylactic mastectomy. And my breast surgeon, again, told me I was being aggressive and to come see her in a year. So I guess my question is, how do we not only continue to educate about BRCA and genetic testing, but also about these other mutations that people are saying the correlation to cancer might be lower, but it's only because they don't necessarily have the data. And just so everyone knows, I saved my own life because they found radial scarring, hyperplasia, a bunch of other things that were ticking time bombs. So just want to make sure that everyone knows that there are other genes, as you're aware. And one last thing is that there is a genetic testing company called jscreen.org. Not promoting, I'm just making aware. It's an at-home saliva test, and if you don't have insurance, I think it's $3.99. If you have insurance, it's $1.99, whether your insurance covers it or not, and they test for over 70-something hereditary cancer genes. I have a geneticist on site, but I've never used that person. So.
You just highlight, it's not just BRCA. It's these, cancer panels. They're growing. Some have high risk of cancer. Some are moderate risk. Some are low risk. But everyone's different in terms of what risk-reducing surgery, imaging, what works for them. Just going every 6 months, even for maybe a low-risk mutation, that's stress every 6 months, waiting for the results. Did it get me? Did it not get me? Okay, I'm good now. Okay, 6 months later. That's a lot of stress. And for some, that's not okay. And I think empowerment is, a take-home message is that if you have the knowledge, you can come up with a plan that works for you. And someone else may not choose that. Someone may not choose to screen out the check gene. Someone may not choose to screen out the BRCA gene. Some will, some don't. It's unique. There's, everyone's different, and you could take certain measures to set yourself up, and reduce those risks.
And advocating for yourself when no one else thought that maybe you needed to. Right. Stepping up and saying, hey, you know what? I think something's off. It's also my body. I only get one of these from birth to death. This is my vessel, so it's your body, and you did the right thing. And congratulations for sticking up for yourself and for saving your own life.
What are your thoughts on BRCA patients associated with pancreatic cancer?
They're starting to have pancreatic screening programs, so we have one in, I refer to someone in the city. Definitely, you should do screening. They say, look at the family, but, if you're the only person in the family that gets pancreatic cancer, it doesn't really matter. I think screening is what we have right now. Screening's not perfect, but it's gotten a lot better. Pancreatic cancer is very hard to screen for.
Yeah, I'm actually on a study now for it.
Yeah,
A
so I
study,
definitely talk to my patients about potentially screening.
I just feel like the more I know or the more I can find, I can test, why not?
Sure.
I just feel like the more knowledge, the better,
Yeah, I agree with that. I think it's an important thing. The risk is low, but it's, pancreatic cancer, unless you find it early, is not curable, so.
Right.
Thanks for tonight. This is really informative. It's all about education and knowledge is power, but how would you recommend getting this information on a weekly, monthly basis? Obviously, I'm not, going to my doctor at that cadence at this time, and how would you also recommend having those conversations with your family members about your genetic history? Maybe it's something you bring up at the dinner table. I'm just curious, A, to have those conversations, and B, recommendations you have to get this information on a more regular basis.
Honestly, of course, every family is different, but I think it's very important to know in terms of the family if there are any cancers and what was the reason, what happened to Aunt Janie, 55 years ago. Do we know what happened, and is it cancer? And it's important once you see your primary care doctor or regular OBGYN is filling this information. And sometimes the doctors unfortunately don't ask, but it's important to be there. It's very important because, for example, when patients see me, I make sure that I know everything that needs to be known, but the reality is that most of the broad community doesn't necessarily ask these questions, unfortunately.
Hi, I'm Elaine Jaworski. I'm a gynecologist, and I had a question for some of the genetic counselors in the room. I was trained to have my patients see genetic counselors before they receive genetic testing, so in residency I wasn't trained to really give genetic counseling. I'm now in an area that has no genetic counselors. I myself have probably my identical twin is positive, so I'm awaiting my results. I've been waiting over a year to see a genetic counselor myself. I'm curious, my office today offers, I can order a panel for ovarian and breast cancer, but I do not feel equipped to the level of you guys to provide genetic counseling. I personally feel like I don't want to create a barrier, but I also don't feel that I can provide as much information, and I'm just curious your perspective and opinion on that, if that seems reasonable, or if you really think they should be seeing a genetic counselor first.
I don't actually think it's reasonable to expect physicians who are experts in other areas to keep up with their field of medicine as well as the field of genetics, which is moving at a extremely fast pace. And I think that it's moved so fast that everyone is really struggling to keep up, and how do we provide care, and how do we provide access. I would say in your instance, and there are really excellent now telehealth genetic counseling services that can kind of fill in some of those gaps and provide access in areas where there may not be genetic counselors available. So I think that my recommendation would be to try to connect with some, or make yourself aware of some of the telehealth genetic counseling services that might be available.
Back to insurance. Some insurance companies won't pay for genetic testing unless they see a genetics counselor first, which again, I feel is a way around to try,
Yeah, so we
trying.
like prior auth and make sure prior to,
Yeah.
but yeah.
So I actually offer a lot of genetic testing in my office. So I do it. I do it and we get the results. Most people are negative, so it's easy. You know, and I'm screening only for really breast, ovarian, and the connected genes, and they understand that. I have a very basic conversation. This is what, and you know, we offer it. I think anyone with cancer we talk to about, even if they were diagnosed 10 years ago, we're talking about those patients today, saying that they can consider genetic counseling because it is so impactful. Like, we're surprised sometimes when people come back and they're positive. So we sort of deal with the backlash on the other end, because we get a lot of variants of unknown significance, and then we get the positive results, which obviously we can help them with. So yeah, we have a genetics counseling office, but they can't handle it. There's too many. It's just too many. There's too many patients. Like everyone that had cancer getting tested, that's a huge number. So that is how we sort of do it. We just sort of do it. And then a lot of the companies that we use have a genetics counselor that will call the patient. So it is sort of tied into it. So if we can't get them into a genetics counselor, they're going to be able to speak to someone, but it's going to be after the fact. It's not before.
Also, something that is important is retesting. So, for example, family history, and the test was done 10 years ago. That test may not be valid anymore. I usually tell my patients to repeat it every 5 years with a negative.
I genetic tested, the positive, BRCA1, the whole bit. Signed up, got my date for my, hysterectomy and my mastectomy and the whole thing. And as I was, no joke, it was like the day before, I think, I happened to talk to the geneticist, and she's like, do you want to retest just to double check? I'm like, you're kidding, right? Like, now is when I want to, I don't want to retest now. I'm literally being wheeled in to have everything sucked out. I'm not no. Retest before you walk into surgery. That's my advice to you. If you want to retest.
Thank you. These questions are for you, Dr. Lederman. I have two. I mean, relative to the cost of genetic testing, I imagine that freezing one's eggs is, I know, it's very expensive. So I wonder if you are BRCA, there's insurance coverage for that. That's my first question.
So some insurances will cover, IVF, some cover IVF insurance conditions, some will cover for genetic reasons, some will cover egg freezing. There are actually a lot of big companies now work with, these, there's certain like third-party payer, and they'll cover freezing eggs, freezing embryos, and things like that. Just they don't have to have infertility. They have the benefit to do that. A lot of the bigger companies now are doing that, but that's the bigger companies. Some insurances will cover it. A lot don't though. For a reason, even if they have a medical reason, to freeze eggs. So we work with certain organizations that help sometimes fund those cycles. Medications, we often will give them, they'll get discounted, just like when a patient has cancer, we get them in, we get them discounted, rates if they're out of pocket or if they can't get an organization to fund it. Oftentimes, they could get these treatments at a reduced cost because it's not cheap, and hopefully when it comes to fertility, more and more insurances will cover it, but they should also cover for certain reasons. There are just like BRCA, some patients have a risk of early menopause. There's certain genetic conditions that predispose that. I saw a patient recently who has a unique, rare condition that's associated with early menopause, and she was considering freezing her eggs in her early 20s because of that risk. So we're not there yet, and we try and figure out a way to make it work. Oftentimes we'll have medications donated from a patient, and if they have to pay out of pocket, we'll give it to them. We do what we can to try and help them out, in those conditions.
My second question relates to your statement that the difference between freezing embryos and freezing eggs and the thawing rate is getting closer, but I wonder what the difference is.
So in the old days, when we froze eggs, it didn't really work that well. And the reason it didn't work that well, the old way we used to do it was a process called slow freezing. Now we freeze eggs the exact same way we freeze embryos, which is a process called vitrification. Fancy word, it's just a rapid way of freezing eggs and embryos. That's been a game changer, you know? And just to kind of give you an idea where we are with eggs, you know, some women can't get pregnant on their own because they're early 40s, mid 40s, late 40s, and they have to use a donor egg. Or even some younger women, you know. The old way of doing a donor egg is we would find a donor, it would stimulate them, take out their eggs, and combine with the partner's sperm. Now, just like there's a sperm bank, there's an egg bank. There's a frozen egg bank of eggs that they could choose, which works just as good. It's actually faster and sometimes cheaper. So we've come so far with eggs, you know. So, you know, the benefit of embryos, if they have a partner, is you can check the chromosomes. With eggs, you can't check any genetics, so you know nothing about them. You know, also there's a flexibility thing when it comes to eggs and embryos. So for a patient who's not sure about the partner, they may not want to freeze embryos because if they split up, you're not going to want to use it. With eggs, you get the flexibility. Embryos, you don't get the flexibility, but you can test chromosomes or other genetic mutations.
Are we gonna just sort of hit pause for a second?
Yeah, I think
are
we're
we?
good, right? We don't have any more questions.
I just have to tell you, like, I honestly thought I knew just about everything there was to know about BRCA. I went through it, I lived it, I had all the complications we talked about. I mean, I was in it, I read the whole bit. I mean, I was throwing words around like expanders and nipple preservation, but I didn't even really scratch the surface until I spent what was just like the last hour and a half with these really smart, you know, doctors and researchers and scientists and patients and people who have stories to share. So the more you talk about it, the more you discuss it with people, your doctors, each other, family members. You know, there's so much research being done right now. And Dr. Bernik promised that in 15 years, my kids, she was like, I swear to you, it's going to happen. We heard it here first. Record this and record it somewhere. But listen, everyone here, at least one thing, we're all on the same page to help prevent, treat, and care for those touched by BRCA or by breast cancer. So a huge thank you to all of you guys for sharing your insight and your wisdom tonight and your personal stories, and you guys as well. Thank you guys so much. We really, really